Welcome to the HealthspanMd podcast. Welcome to the HealthspanMd podcast, where we delve into the latest insights, strategies, and science of longevity. Today, we are going to talk about one of the most powerful tools that we have to understand an individual's risk for heart attack, stroke, and death. And that tool is a coronary artery calcium score. And it's something that we get a lot of questions about. And why are we talking about coronary artery calcium scoring and longevity? Well, because heart disease is the number one cause of death. If we want to live a long time, then having healthy heart arteries, that's a really important aspect of achieving that goal. And in today's podcast, we will answer several questions about coronary artery calcium scoring, like what is it? Who should get one? Who should not? What does it mean? Why a high coronary calcium score can be a blessing? And does it mean you need a stent in your heart arteries? And joining us today on the podcast is Dr. Lisa Hurst, who will be asking me the most common questions we get about coronary artery calcium scoring. So Dr. Lisa Hurst is a board-certified internal medicine physician, did her residency at Mayo Clinic. She's a consultant there for over 20 years, retired recently to open HealthspanMd Primary Care because she wanted to provide expert, cutting-edge, proactive, whole-person primary care in a practice that accepts Medicare and most insurance. Welcome to the podcast, Dr. Hurst.
Thank you very much. I'm excited to be here.
Okay, so let's dive in. What's the first question?
All right. What is a coronary artery calcium score?
Okay, so coronary artery calcium score is derived from a CT scan. That's an X-ray test of the heart arteries. So we've known for a very long time that when artery disease develops in any artery, part of that is calcification, and we can see them on a CT scan. A CT scan is really good at picking up that calcification. So many years ago, one of the preventive cardiologists, Arthur Agatston, was realizing that, hey, this could be a really great tool to help us understand an individual's risk. They decided to put together a system for how to quantify that amount of calcium, which is, ironically or not ironically, called the Agatston score. And using that information, we learned that when we scan people and then looked at that, given them a score, and then followed them over time, it's a really powerful predictor for heart disease. And one of the things I want to say about this is that if you're one of those people that has a high coronary calcium score, this can be a blessing because we do know some people may have a predisposition for artery disease, whether it's genetic or some other factor that we may not otherwise recognize before they have the heart attack. The coronary calcium score can be that tool that gives us that insider information to know what's going on before that serious event. And, waiting for heart attacks, one of the things that it makes sense to people. They're like, okay, well, waiting for a heart attack to occur before I prevent it, that doesn't make sense. What's under-recognized is the consequences of heart attacks. 25% of the time, the first sign somebody has heart disease is they die. Sudden cardiac death. About 300,000 people every year in the United States alone have a sudden cardiac death. So this coronary calcium score, very powerful tool to understand who might be at risk for heart disease before those devastating events.
All right. How about who should get a coronary artery calcium score?
Okay, so coronary calcium scores shouldn't be done by everybody. Not everybody needs this. The best indication for a coronary artery calcium score is when we don't know what that individual's risk is. So the most common scenarios or situations where I, as a preventive cardiologist, is seeing somebody and wondering, okay, well, is this person at higher risk than I'd otherwise think? The biggest one is family history. They have a family history of heart disease. A lot of times they made different lifestyle choices than their afflicted family member, but they're still unsure. Did they get the bad genes or did they not? Coronary calcium scoring or other imaging like a carotid ultrasound can be that answer. Other situations when the cholesterol is high, but that individual is young, so they're low risk for near-term events from a heart disease, but they're concerned because their LDL cholesterol is, let's say, 150 to 180, somewhere in there, and they're thinking, okay, do I need to treat this or do I not? Coronary calcium scoring can help answer that question. And then another one, a real area of burgeoning interest is Lp(a). So, Lp(a) is the most common cholesterol genetic variant associated with early artery disease. And so it's increasingly being tested for. It's a blood test. People are finding out they're high Lp(a). Does that mean that they need to get more aggressive about their prevention regimen? A coronary artery calcium score can help us answer that question.
Does a high coronary artery calcium score result mean I have blockages in my arteries?
So the answer is no. So there's some correlation between calcium scoring and blockages in arteries, or what cardiologists call obstructive coronary disease. And that means a blockage generally that's more than 70%, because that's when the body's mechanisms for compensating from narrowing of the arteries is overwhelmed, and they can't keep blood flow going to the heart muscle, and that's when we usually intervene on arteries. But there's some correlation, but it's not very strong. I've had patients who had calcium scores over 4,000, no blockages in their arteries, and the opposite is also possible as well. Somebody could have a calcium score of 0, and it's a soft plaque that's ruptured, and they have 100% occlusion. And so they do not mean the same thing. A coronary calcium score is a test for risk, whereas the other tests, like a stress test, a nuclear stress test, a CT angiogram, a direct coronary angiogram, those are looking for blockages. Those are different tests with different indications.
So you mentioned scores of 0 and up to 4,000. What do different coronary artery calcium score ranges mean?
Okay, so a score of 0 is the easiest to explain. That means, of course, no calcium in the arteries. And that's an important finding because those people are at low risk for at least the next 5 and maybe even 10 years of having a heart attack, a stroke, or dying from heart disease. And it depends on the studies. Generally, most of the data is that risk is about 1 to 2% over the next 5 years or so in somebody that has a calcium score of 0. I have seen, some of the older data showed a event rate or a heart attack rate of about 4% at 5 years. But I think most of the data is that low risk 1 to 2%. So it's not a guarantee, but it's not far from it, that person's not going to have a heart attack, stroke, or death in the next 5 years. So the next level of looking at these are the mild risk. That score is generally thought to be in the double digits, or single to double digits, so from 1 to 99. Moderate risk is a calcium score from 100 to 399, and then greater than 400 indicates a high risk of disease. But I think a better and more meaningful way for me to assess a coronary calcium score is based on the percentile that's adjusted for age and gender. And that's because that while the absolute score is helpful and especially easy to understand when we're looking at populations of people, when we're looking at the individual, though, and their risk, the score relevance of it is highly determined by the age. So if I see a calcium score, for example, in a a 40-year-old that is 100, that's really high. Like that's going to be, 99th percentile. But a score of 100 in an 85-year-old, that's, probably going to be, 25th percentile or something like that. So if we're really wanting to individualize that person's risk assessment, the percentile is the number that I pay the most attention to.
So this next question I get a lot in my practice is, how often should I get a coronary artery calcium score test? Is it a good way to measure the success of my prevention strategies?
Yeah, wouldn't that be great if it was? Because, one of the things that we've struggled with in cardiology and preventive cardiology is how do we assess the effectiveness of our prevention regimen. Now, if we do optimize the surrogate markers for risk like blood pressure and cholesterol and blood sugar, insulin, those are really valuable because we know we get those great people have 80 or 90% less heart disease, but it still doesn't really answer that final question is, well, how good are we doing? Like, are we really stopping artery disease? Are we regressing artery disease? And unfortunately, calcium scoring does not answer that question. It is always going to get worse over time, whether you do all the right things, whether you do all the wrong things. So once somebody's had a high calcium score, I cannot think of any reason why they would ever get that calcium score done again, unless they just want to be depressed, because that's what happens every time. When I see somebody who's had a repeat calcium score and they're just so dejected because they're like, it got worse. I'm trying everything. I'm taking my statin. I'm exercising. I feel great. And my calcium score went up. And I have to, talk them off the ledge and say, yep, that's what happens. Like, don't get it anymore. But there are situations where you would repeat the calcium score, and that's when it is 0. So if you had a calcium score of 0 and you decided with your doctor at that time, okay, I'm not going to take a statin, for example, or I'm not going to do anything else around my prevention regimen, you might decide that you want to repeat that calcium score. Is it 5 years? Maybe 10 years, maybe. I think it depends on the age that you do that first one, but that's the only scenario that I would recommend repeating a calcium score is if it's been 0 in the past and you're older now. Is it still 0 and you want to know that? Then that's a valuable time to repeat the calcium score.
Okay, so if I've had a calcium score done, how do I lower my calcium score if I want to have it done again?
So as general, you will not lower your calcium score. There's no proven interventions that lower the calcium score. But I will say this, that's not really the point. I make this, give this kind of story to my patients all the time who come with a high calcium score. One of their questions always is, how do I make my calcium score better? And they're discouraged when I tell them, well, you can't. There's nothing that I know of, nothing proven. I know there's some claims out there that they can reverse the calcium score. I've never seen any credible, data on that. But what I will say is this. Making the calcium better is not the main objective here. And in fact, this is a disconnect for people. The calcium's not the problem. It is a measure of risk, but calcium is old, hard-healed artery disease that is not going anywhere. It's the soft plaque that we're worried about. So calcium is just a surrogate marker, basically, for that risk. And if I told a patient who came with a calcium score, hey, I have this great thing that's going to make all the calcium go away. And they're like, oh, great. It's going to make my arteries look better. And I say, yeah, they're going to be amazing. You're going to have a calcium score of 0. And then they said, oh, and so that's going to lower my risk of heart attacks and strokes. No, it doesn't do any of that, but it makes the artery look better. You'd say, okay, that's not of much value. I think the opposite, though, is true, is that we have a lot to do to lower the risk.
So if I can't lower my calcium score, does that mean there's nothing that I can do?
So there is so much you can do if you have a high calcium score. So, the high calcium score indicates risk. But remember when we talk about these data and their indication for risk, these are in people that we didn't do an intervention on. We just looked at their calcium score and we followed them over time because we didn't know what it was going to mean and found out high calcium score, higher risk for heart attacks and strokes and death. But what I will tell you from my experience, from the research, is that we are really effective at preventing heart disease once we know somebody's at high risk. If we can optimize the risk factors, the drivers of artery disease, we can prevent 80, 90+% of heart attacks. So although you can't lower your calcium score, that does not mean there's not anything you can do with a high calcium score.
So does a high calcium score mean I will have a heart attack?
So it does not. It's not an absolute. I mean, even people that have scores over 400, their risk for a heart attack in the next 10 years is about 25 or 30%, depending on the study. But again, that is in people that are not treated and optimized for their prevention. We can lower that number significantly. Now, those studies have been done. It's anywhere from, 35, 40% lower risk. Although I will say, I think we can do better. I think, those are done on pretty modest prevention regimens. I think when we get LDL cholesterol really great, we get blood pressure great, we get blood sugar insulin great, we get the lifestyle choices lined up, nutrition, physical activity, sleep, stress, avoiding toxins, all consistent with that patient's long-term health goals. I believe that most of that artery disease, that those event rates are preventable. That's just been my experience in, 25 years of doing this.
Okay, so I've been told that I have a coronary artery calcium score that's really high. Does that mean that I now need to get an angiogram or even a heart catheterization?
Yeah, probably you're going to, even though I don't think that's the right thing. So one of the criticisms of calcium scoring is that, and this has been shown in studies as well, is that it often leads to more testing. So high calcium scoring leads to an angiogram, which leads to a stent. And, the detractors or the people that have been against calcium scoring are saying, look, we end up doing all these tests that don't change outcomes. These have not been shown to lower the death rates, lower the risk of heart attacks. And I think those are valid concerns. In my practice, high calcium score does not equal angiogram or heart catheterization. I think some testing is indicated. Certainly if there are symptoms, that's a completely different story. If somebody, comes to me with a high calcium score and they have a classic story for exertional angina, I'm going to want to know what their arteries look like. But in somebody who's not having any symptoms, they have a high calcium score, it depends on what their other risk factors are, what other things are going on. But at most, what I'm going to be interested in is their lab testing. What's their cholesterol? What's their blood sugar, A1C? Potentially an echocardiogram, potentially having them run on a treadmill. Although I will say that's as much for patient reassurance as it is for the science of how to manage their artery disease. But it's not often that somebody in my practice has a high calcium score with no symptoms, ends up with an angiogram.
So if I have a high calcium score, do I need possibly to get a stent then?
So the correlation between a calcium score and blockages in the arteries is relatively weak. So most people with high calcium scores do not have blockages in their arteries, but it gets complicated because the other factor that's under-recognized by patients, but also doctors a lot of times, is that discovering blockages in somebody who does not have symptoms and fixing those blockages almost never changes outcomes. I mean, does not change death rates, does not change heart attack rates. And if they don't have any symptoms, we definitely aren't going to make them feel better. So I think this is where that murky area comes in, the detractors to calcium scoring that say, look, you do a calcium score, but then it leads to all these other tests. I think they have a valid point that, if we are, using the calcium score to then do an invasive angiogram that then finds an asymptomatic stenosis of 70%, and that person walks out with a stent, I'm not sure that we did the best care for that individual. So I would say the most of the time that is not true, that you do not need a stent. Now, I do want to put some nuance to that discussion though. And I had this from a patient recently. He had a calcium score that was high. We did a stress test, an echocardiogram. His heart otherwise looked good, but he was nervous. He was anxious about the high calcium score. So he wanted to get a CT angiogram, and he did. And he had blockages in his heart arteries. Still, he's optimizing his risk factors. We had all these, we've taken advantage of all these opportunities to get his health better, but it weighed on his mind. Like, he was worried all the time. He ended up, having some very atypical chest discomfort, almost clearly musculoskeletal, was not related to his heart, but he went to the emergency room with this because he was worried. And, in the end, he ended up with a bypass surgery. And, I on one hand, I think somebody who, understands the medical literature would say, okay, well, he didn't get the right treatment because, there's no evidence that bypass surgery is going to change his risk for death rates or heart attack rates, and he was asymptomatic. But I would argue the other way as well for him is that he needed that for his peace of mind. It doesn't, knowing that medical treatment is not worse than putting stents and bypass surgery in medical treatment does not mean that you just do medical treatment. There are indications for procedures like stents, like bypass surgery, that are not just death and mortality benefit to them. Those are equal in outcomes. In this individual's case, this is what he needed, and that's what he got. But in general, most people that are needing or have a high coronary calcium score do not need stents in their heart arteries. All content created by me and HealthspanMd is for general informational purposes only and is not the practice of medicine. No doctor-patient relationship is formed. The use of this information is at the user's own risk and is not a substitute for professional medical advice, diagnosis, or treatment. Hi, I'm Dr. Hurst. We created HealthspanMd for people who are dissatisfied with healthcare. Common complaints about healthcare include difficult access, poor communication, rushed appointments, disease-focused or sick care with little interest in helping people get or stay healthy, and little to offer beyond a prescription or a procedure for optimizing health. This type of healthcare is unacceptable, but most aren't aware that they don't have to accept low-quality healthcare. HealthspanMd provides exceptional medical care. That means appointments when you need them, time to talk to your doctor, get your questions answered, understand your problems, and get a clear plan to achieving your health goals. But it also means a comprehensive, proactive approach to your health that goes beyond prescriptions and procedures. As a HealthspanMd patient, you will get our expert, physician-led team of doctors, health coaches, dietitians, exercise specialists, mental health, and other health professionals to help you take advantage of your best opportunities to prevent, treat, and even reverse disease. And you may be eligible to have our care model reimbursed by Medicare and some commercial insurance. If you're no longer willing to settle for low-quality healthcare, schedule an appointment at HealthspanMd to experience healthcare as it should be.